Welcome to this video, Sertraline and the Platelet, a tale of two dysfunctions. We will be understanding the dual mechanisms behind sertraline-induced bleeding. Sertraline, a widely prescribed SSRI, can increase bleeding risk. This effect is often attributed to platelet dysfunction. The core question is the problem with how platelets work, a functional issue, or how many platelets there are, a quantitative issue? There are two distinct paths to this single outcome. Path 1, the common functional defect, involves sertraline impairing the ability of platelets to aggregate. Path 2, the rare quantitative defect, triggers a process that actively reduces the total number of circulating platelets, causing true thrombocytopenia. Path 1 is the common story of serotonin starvation. The most frequent cause of bleeding is a functional impairment caused by the depletion of a critical signaling molecule, serotonin or 5-HT. The mechanism involves blocking the serotonin gateway. Platelets rely entirely on absorbing serotonin from the bloodstream via the SERT transporter. Sertraline blocks SERT, preventing platelets from replenishing their stores, leading to depletion over weeks. The consequence is a muted, call for help. Normally, activated platelets release 5-HT to amplify clotting. With depleted stores, this release is weak, leading to impaired aggregation and increased bleeding time. This can result in signs like easy bruising and prolonged bleeding. Path 2 is the rare case of platelet destruction. In rare instances, sertraline actively reduces the platelet count, causing true thrombocytopenia, which is a platelet count below 150K. This can lead to more severe risks, like petechia and spontaneous bleeding. The primary mechanism for destruction is drug-induced immune thrombocytopenia, or DITP. Sertraline acts as a trigger, stimulating the production of drug-dependent antibodies. These antibodies bind to platelets in the presence of sertraline, flagging them for destruction by the spleen. Other less common quantitative mechanisms include bone marrow suppression and hypersplenism. While these are plausible, immune-mediated destruction remains the most cited cause of true sertraline-induced thrombocytopenia. In this head-to-head comparison, the functional defect is common and results in weak platelets with a normal count. The quantitative defect is rare, resulting in a low platelet count or thrombocytopenia. Both resolve after drug cessation. For clinical synthesis, the most critical diagnostic step when a patient presents with bleeding is the complete blood count. A normal count suggests a functional defect, while a low count suggests true thrombocytopenia. Understanding this fundamental distinction is key to management.